Okay, well, welcome everyone to our webinar today, facilitated by the Dissemination and Community Engagement and Education and Scientific Development Units of CAPES, the Center for Accelerating Practices to End Suicide. We're thrilled for our speakers today. The title of their presentation is Suicide Prevention Implementation Across Diverse Healthcare Settings Using the ECHO Model, Lessons from the American Foundation on Suicide Prevention and American Academy of Pediatrics. So our presenters today include Dr. Corbin Stanley, who's a community psychologist and Senior Director of Impact Communication and Continuous Improvement at the American Foundation for Suicide Prevention. He leads the continuous improvements and evaluation of AFSP and partner programs and initiatives, drives communication efforts to disseminate AFSP's reach and impact, drives organizational learning through comprehensive needs assessments, continuous improvement approaches, and evaluation initiatives, and lends his analytic DEI and translational science expertise to inform community, systems, and policy change. Then Kristen Kasiksa is Manager of Suicide Prevention at the American Academy of Pediatrics and focuses on youth suicide prevention, educating pediatricians and support teams on clinical and community suicide prevention strategies. This includes suicide screening for youth, assessing risk and areas of support, and building and sustaining clinical community relationships using the blueprint for youth suicide prevention. Then Jessie Leffelman is Manager of ECHO Initiatives at the American Academy of Pediatrics. Her role includes the development, coordination, and implementation of ECHO program activities, as well as assisting with the dissemination of program findings. She worked on over 15 ECHO programs at the American Academy of Pediatrics, including those on substance use, telehealth care, COVID-19, and suicide prevention. So, please welcome to the webinar, and I'll hand it over to you, Dr. Stanley.
Awesome. Thank you, Laura, for the introduction and for helping to coordinate all of this. Thank you, Dr. Boudreau and the CAPES team for the invitation. And thank you all for joining us today. We're excited to share some of the lessons we've learned implementing Project ECHOs in the pediatric suicide prevention space over the last couple of years. And I'm thrilled to be joined by my colleagues from the American Academy of Pediatrics. So we are going to share a few things with you today around our partnership, how the American Foundation for Suicide Prevention and the American Academy of Pediatrics came together to do this work. We'll talk about how we've been implementing Project ECHO over the last few years, primarily in clinical settings, but also in community settings in the pediatric youth suicide prevention space. And we'll talk about some lessons learned as well as some of our dissemination efforts as well. So again, appreciate you all for joining us today. So I want to start by talking a bit about the Blueprint for Youth Suicide Prevention. This is sort of the context for the partnership between our organizations. The Blueprint for Youth Suicide Prevention was released in 2022, and it was co-authored by the American Academy of Pediatrics, the American Foundation for Suicide Prevention, and experts from the National Institute of Mental Health. And it's really an educational resource that's designed for clinicians, public health professionals, educators, and advocates on youth suicide prevention efforts. And there are strategies to support youth suicide prevention through clinical pathways, community partnerships, as well as through policy and advocacy efforts. It's currently endorsed by 19 medical and public health organizations, and it's free and publicly available on the American Academy of Pediatrics website at aap.org/suicide prevention. So I definitely encourage you to check that out. And the reference on the bottom there, Julie Gorskowski-Hamilton from AAP led an article on the development of the Blueprint for Youth Suicide Prevention, which we'll also talk about briefly. And so to inform the Blueprint for Youth Suicide Prevention, AAP and AFSP convened a summit and some focus meetings in 2021. And the summit and these focus meetings really convened cross-sectoral partners and experts to really discuss the context around suicide prevention among youth, as well as the landscape around the science, practice, programs, and policy related to suicide prevention among youth. The goal was to identify concrete clinical, community, and advocacy strategies for promoting suicide prevention among youth. And all along the way, it was grounded in a focus on health equity and lived experience, which is an important aspect of the Blueprint for Youth Suicide Prevention. So there are a lot of takeaways that came out of the summit and the focus meetings. One is that suicide can often be prevented. Two was that health equity is a critical aspect of suicide prevention in all of these contexts. Three was that strategies to improve suicide prevention need to include both resources and tools, but also education on what that looks like in practice and how to implement these resources and tools in clinical and community settings. And the fourth was that cross-sectoral partnerships are absolutely essential to this work. So health systems can't do it alone, schools can't do it alone, families can't do it alone, right? But we need to work across all the places where youth live, learn, work, and play to foster wellness and promote suicide prevention um, in these spaces. And so, in another article we published in 2024, we talk about some specific engagement strategies in each of these areas, and these are also outlined in the Blueprint for Youth Suicide Prevention. And so the AFSP and the American Academy of Pediatrics partnered in 2022 to release the blueprint, but then we really wanted to operationalize the blueprint. One of the things we didn't want to do was just develop a blueprint or a toolkit that was going to be released and then just kind of sit on a shelf, right? We really wanted to operationalize it in a way that made sense for the communities that are dealing with youth suicide. And so we partnered together and continued that partnership through last year, implementing a series of Project Echo initiatives, really focused on healthcare settings, schools, and community suicide prevention. Um, there's a lot of advantages, of course, to partnering between our two organizations. One is the national reach and the chapter networks. Both AAP and AFSP have a network of chapters in all 50 states across the country doing the work of pediatric health promotion and suicide prevention at the local and state levels. So it made a lot of sense to connect those chapters together and implement that work locally. Of course, the complementary subject matter expertise around pediatric health and suicide prevention, a shared focus on clinical care, community efforts, policy change, and our shared goal to reduce rates of suicide in youth and young adults. And so that partnership has been a phenomenal partnership, and we've been so grateful to work with AAP on these efforts. And with that, I'll turn it over to Jesse to talk a little bit about AAP as a super hub for Project Echo.
Thank you, Corbin. So I'm just going to give a brief background about the AAP and Project Echo in case you guys are not familiar. First of all, the mission of the American Academy of Pediatrics is to attain optimal physical, mental, and social health and well-being of all infants, children, adolescents, and young adults. In 2013, the American Academy of Pediatrics officially became an Echo Hub, and just 2 years later, in 2015, we became an Echo Super Hub, which we are still currently the only super hub in the US solely focused on pediatrics. The AAP is a strong, effective advocate for children's health and trusted source for education and breaking news for pediatric professionals. Through Project Echo, we've been able to expand the Academy's impact, connecting pediatric experts with healthcare providers and communities across the nation. This has helped ensure that children everywhere receive the right care at the right time at the right place. And that mission has been at the heart of everything we've done over the past 10 years. Can move on, Corbin. To quantify our impact over the last 10 years, we look at our work in three different categories. Initiatives, can you go back one? One more. Our initiative, our reach, and our training. To date, we've hosted over 140 programs ranging across 40 different topics, reaching folks in all 50 states. We've also completed over 120 hub trainings and do technical support for those. And I do want to, I do want to flag that these numbers on this slide are reflective of 2025, so they don't include anything that we've started in 2026. But you can see we've had an amazing reach over these last 10 years. Next. Okay. This snapshot just offers a quick look at the impact of our ECHO programs from the participant perspective. It includes data on Learnotype, insights into return on investment, and we share evidence reported practice and process changes and participant changes. Again, this is only 2023 through 2025. We started our evaluation implementation in 2023. So you'll see it's just a snapshot in time, but moving forward, this will be updated throughout. And the youth mental health crisis continues to be one of the most urgent challenges in pediatrics today. In response, the AAP has taken bold action, launching over 34 ECHO programs focused specifically on pediatric and adolescent mental health. These programs support providers in identifying, treating, managing, and navigating a wide range of mental health concerns. As you can see, on the farthest on the right is where we highlight our suicide prevention ECHOs, which we'll be talking about a little bit more.
Yeah, thank you, Jesse. And so obviously, given our partnership in developing the blueprint for youth suicide prevention, it also made sense to partner with the AAP given their status as a super hub in the pediatric health space for suicide prevention. So we partnered beginning in 2022 through last year to develop a series of ECHO programs that build the capacity of healthcare professionals and community partners to integrate the blueprint for youth suicide prevention in both clinical and community settings. We'll focus today mostly on the clinical echoes, but we'll highlight a little bit the ambassador echoes as well, which is sort of a novel approach that was worth mentioning. So in our clinical echoes, these were intended to engage community pediatricians and healthcare professionals in quality improvement projects, really to build their knowledge and self-efficacy on best practices for effective suicide prevention care in practice, to foster peer support and sense of community among pediatricians doing this work, to demonstrate practice change related to clinical outcomes. And we did this in primary care, emergency medicine, and school-based health settings. We also launched a series of ambassador echoes, and these were intended to engage ambassadors to establish clinical community partnerships for community change. So this really leveraged our AAP and AFSP chapter networks to engage in community level suicide prevention efforts, whether it was in schools, public relations and media, policy and advocacy, whatever that looked like for their communities. Again, the goal was to build knowledge and self-efficacy on best practices in community-based prevention, again, foster that peer support and sense of community, and to really identify opportunities for increasing suicide prevention education and to influence state level change. And so we wrapped up that grant work with AAP last year, and are happy to share a little bit more about how that process went and what we learned. And I will turn it back over to Jesse to talk a little bit about that.
Great, thank you. I'm here. I'm just going to give a very high-level overview of our clinical echoes. Please know if you have any questions or you would like further conversation about this, we're always open to talking. We love to talk about this program, so feel free to reach out to us at any time. Like I said, I'm here to talk about our clinical echoes. This is just kind of a time frame to show you overall where we were and how many we did. So we did all of the highlighted ones are our clinical cohorts, and all of the non-highlighted ones are our ambassador echoes. Okay, next slide. I think Corbin kind of touched on this before, so I don't need to go into too much detail, but the overarching goal and outcome is really to train healthcare professionals and clinical strategies described in the blueprint, to increase capacity regarding practices to identify and support youth at risk for suicide. So really building up that knowledge, confidence of efficacy and best practices on integration of a suicide prevention care pathways in clinical practice, gain that peer support and sense of community that ECHO is known for, and demonstrate practice change related to identified clinical quality measures. This is overall what a typical AAP ECHO looks like, and this is how we started our program. They're 1 hour. That's what we've been told and provided feedback from our members that 1 hour is all they have. So we cram as much as we can in that hour. We open up with introductions, housekeepings. We move on to the lecture portion and Q&A. Second half is really a case presentation and or facilitated discussion, and then we wrap up and evaluate. Before we began anything, we knew that we just had to identify our subject matter experts and get their input. So we aimed to recruit faculty who represented diversity across their roles and disciplines, practice settings, geographic locations all over the country. We wanted different lived experiences and cultural perspectives, as well as career stages and areas of specialty. It is an all teach, all learn philosophy, an ECHO program. So we wanted to make sure that our subject matter experts came in with that idea and that philosophy as well. We recruited our subject matter experts by reaching out to the authors of the Blueprint for Youth Suicide Prevention and either asking them or asking them for recommendations. We looked at subject matter experts from previous AAP programs and projects with experience on this topic. We reached out to our AAP committee councils or section leaders. And for later cohorts, we actually engaged some of our more involved and engaged ECHO participants. And so we were building up that leadership within the community and within our membership. Once we identified our subject matter experts, the next was to kind of dig right in and get that curriculum developed. So we went back and looked at our overarching goals and objectives and made sure that everything kind of went back to that. So we identified the major content areas and separated them into 8 sessions. We decided that we could condense this as best we could with 8 sessions. At the AAP, we have a range between 4 and 19 sessions, depending on the ECHO program, but thought 8 really fit this one. We adapted this from the Blueprint for Youth Suicide and developed individual sessions and learning objectives and made sure that the learning objectives were actionable and measurable. We built the session contents and activities, including slide decks, case forums, group discussions, polls, putting evidence into practice, which I'll talk a little bit more about later, in resources. And then we identified which faculty would present which lecture and which would facilitate. For our participant recruitment, our goal was to get up to 30 participants per cohort with some flexibility. This did include teams from the same practice and organization, and we really encouraged as many people from the practice that could to join, so they're all hearing the same message. The target audience for our first few were primary care physicians and other clinicians working in a primary care setting. Our recruitment included flyers, email and website templates, registration forms, FAQs, and one cohort we actually created a recruitment video as well to send out. We disseminated this all through our AAP committee councils and section listservs. We disseminated it through previous ECHO program listservs. Information included in newsletters and messaging to AAP leaderships and groups. We engaged our faculty and previous ECHO participants to promote the programs, and we partnered with organizations that had aligned goals. So over the course of the project, for our clinical ECHOs, there was 276 individuals representing 205 practices that participated in the educational ECHO program. So we did notice early on, though, that we needed to change a little bit with how we were completing our ECHO programs and our ECHO sessions. We received feedback from our participants pretty early on that this was great information and they were very excited to listen, but they needed more information on how to translate what we learned in the ECHO sessions to what they can be doing in practice. So starting with cohort 5, we changed a little bit, if you go to the next one, with how we run our ECHO sessions. So as you recall, before we had a lecture for the first half, basically, and for the second half, we had a case discussion or facilitated discussion. Well, based on the feedback, we revamped the program to include a putting evidence into practice component. As I said, the participants in the early cohort shared that the sessions were valuable, but they needed more actionable items, more practical steps that they could apply, that they could leave that session at that moment and immediately start working on implementing a suicide prevention protocol within their practice or starting the screening wherever they were in that process, that they could start right then and there. So this portion of each session was designed to help participants translate that key evidence into real-world practice, identify concrete strategies they can implement immediately, and they left each call with a new tool or approach to try that same day. So we did end up changing our ECHO sessions, starting with that third cohort. So we increased it to an hour and a quarter, so 1.25 hours, hour 15 minutes, however you want to say it. Because we didn't feel like 1 hour could capture enough of what we needed. And to be honest, we did not see a high drop off after that 1 hour. Most people stayed for the hour and a half. So we kept the beginning the same, introduction, the lecture and Q&A was 20, 30 minutes. And then the remainder of the session was really this putting evidence into practice and discussion, and then wrap up an evaluation again. But I'll go into a little bit more examples of what a putting evidence into practice would look like. If you Go to the next slide. There we go. A few examples are one of our early on was featuring an interview with a past ECHO participant who successfully implemented a suicide prevention protocol within her practice. So she came on and she shared practical strategies. She told her story, her journey of how getting leadership and staff buy-in. And then our group had the opportunity to ask questions, to go hear directly from someone who had just gone through it and see what they can do and what they could learn from her, what worked, what didn't work, and see if it translated within their practice themselves. Another thing we tried is small group discussions in breakout rooms where our participants talked about where they were in the protocol implementation process. Maybe they were screening already, maybe they weren't screening, maybe they had a great assessment up, but maybe the referrals were needed. So they went in these small breakout rooms. Each one had a subject matter expert and an AAP staff member. And then each participant got to tell where they were at and then ask questions or learn from their peers and the subject matter experts some actionable items on how to move to the next step and get their questions answered in a smaller group. We then would reconvene in our larger group and go over what was learned to try and make sure that people didn't miss what was talked about in each breakout room. And then finally, one of the other ones that was really needed and we kind of just added at the end is we kept hearing about how there's this high level of burnout amongst our physicians, among our participants. So we added a section on self-care and reflection. So we discussed strategies to support clinician well-being through practice change and shared tools and resources. We had the individuals share things that they do within their practice to professionally try to stop burnout. We actually had one session where we had an individual teach breathing techniques that they could take with them and teach to either other people in their practice or use themselves. But really, the shared tools and resources that came out of that was the neatest part. Some of our clinical echoes also had a quality improvement project associated with them. So the QI aim was for pediatric primary care practice teams to improve universal screening and follow-up practice for suicidal ideation and behavior amongst patients aged 12 to 21. So teams use the QI methodology to develop and implement effective strategies that increase compliance with standard of care guidelines, including performing and following up on suicide screening with assessment, referral to mental health, safety planning, lethal means counseling, and connecting families with resources. The benefits of the participating in the quality improvement portion, so this would be an add-on to the educational echo portion, is that they could measure any progress quantifiably across the program. They'd improve the quality of care for their youth patients, expand skills and confidence following best practices, engage with others in similar roles, utilize support from an expert QI coach, develop an effective processes and workflows that are specific to their practice. And then we did award 25 MOC Part 4 points to those who met the requirements. Which is this? The requirements are to establish that core QI team. So we didn't want the physician to do this alone. We knew that it takes more than just one person to implement these projects. So we asked there to be a team and meet with that core team, maybe monthly if that works. Collect and submit data for 7 monthly cycles. We'll go into what that data looked like in a minute. There needed to have been at least one person from their team on each echo session live. They would need to participate in PDSA cycles and data review with our QI coach, end up being about a monthly time frame again, and then complete the project surveys. This is what our measures look like. And to begin with, it looked a little bit different, I'll be honest. When we first started in our first cohort, we had 8 measures and we were asking them to collect it from 30 patients a month. We learned very quickly that this was not possible and not easy for our clinicians who are working in practice. So after that first cohort where we really didn't get a lot of traction and we didn't get a lot of people to join us in our QI, we sat down, reevaluated, and really stripped it down to what we thought was the important measures that we could capture from our quality improvement projects. So, administering the universal suicide screening, conducting a brief suicide safety assessment, referring mental health evaluation, and then a balancing measure. So, we changed to just these four and then 15 charts per month instead of the 30. We had four practices who joined us throughout this journey, and this is just kind of an overview of what each of them really focused on for their projects. So one was to implement Youth Suicide Blueprint and follow those guidelines. One was to design and train providers on suicide prevention protocol, and then develop an underlying infrastructure. One was to build systems, communication strategies, and infrastructure, and then build reliable systems, communication strategies, and infrastructure. They all kind of focused on the same thing, but what was needed for each of the practices. We did have a post-project survey that we sent out after each cohort, and we did find that those who engaged in the monthly echo sessions were more likely to drive practice change and implement suicide prevention protocols in their healthcare systems. Data indicated that the participant capacity for practice change related to suicide risk and screening increased. Emergent themes from key informant interviews and meeting notes showed attrition in participation was due to physician burnout, capacity to continue new projects, and professional and personal conflicts, which was reflected in our QI first session when we weren't able to get as many as we thought. And then out of all the respondents who completed the survey, 95% reported increase in knowledge and confidence in implementing a suicide prevention protocol within their practice. And the areas that recorded the most increased were identification of validated suicide risk screening tools, brief interventions to care for youth who are not at risk for imminent risk for suicide, and strategies to identify mental health resources in their community. Of those who have responded, 81% indicated desire to change their practice flow because of participation in this program. Some of the qualitative responses are listed here on this. I'll say it was so valuable to get this feedback, the qualitative ones that we were able to obtain through our post-session surveys as well as key informant interviews. So we see that the suicide risk screening and assessment implementation was talked about a lot, and being able to implement in their practices after joining this program increased. Also, a lot of them mentioned working key phrases or screening into their EHR systems. And then one that I find neat is the second to last is creating a resource to keep within the exam rooms for physicians and personnel. So on one of our sessions, a subject matter expert had mentioned offhandedly that she had created this binder that just had everything that she needed in it, including scripts and counseling and outside resources. And it was her green folder that she took in with her when she was working with patients. And this just really took off within this cohort. And all of a sudden, they were talking about what colors they were going to make their binders. And it really was one of those things that a lot of people walked away with for that actionable item and were able to create for their practice. We realized pretty early on that primary care physicians were not the only audiences that needed this information or requested this information. So we looked at emergency medicine as well as school-based healthcare settings to be able to implement echo programs as well. Same kind of process, running these echoes, creating these echo programs as before. Project staff identified subject matter experts within these specialties to serve as a program faculty. They revised the curriculum to ensure content was relevant and tailored to each audience. We had that working outline from our primary care curriculum, but know that each setting, it's going to be different. So we took and changed the learning objectives and focused on other areas that were more relevant to their audience. We expanded recruitment efforts to engage participants from these practice areas, and then we ended up launching 2 cohorts of the school-based healthcare content and 1 of the emergency medicine content. I'll speak real briefly about the emergency medicine content. We had 69 healthcare professionals who joined us for that ECHO cohort. A post-session survey was shared after each session, and overall participants reported the curriculum content and subsequent discussions were useful and relevant to their work. They also, 91%, responded that they have confidence in their ability to apply the skills learned in the program. Again, the qualitative feedback was very interesting, and we learned a lot from that. One of the main things is a lot of people who joined weren't aware of the statistics or the scope of the problem. So just drawing attention to that was step one. We got a lot of feedback about how they liked the format. And then, of course, having local and national resources available to share with them. We did cut down the number of sessions for the emergency medicine cohort. We ended up with 6 instead of 8 due to time. And so you can see this here. Also, I believe at the end of the slides, if you look at them, it also lists all the topics as well as the learning objectives for each of the sessions as well. Like I said, we also implemented this program for 2 school-based healthcare cohorts. We had about 65 healthcare and school-based professionals join us for those. Again, post-session survey was shared after each session. Overall, the participants reported that the curriculum content and discussions were useful and relevant to their work, 96%. And they indicated that their confidence, increase in confidence in applying the skills learned. All of the people who responded in our post-program survey self-reported increase in knowledge and confidence implementing the suicide prevention protocols within their institutions. And areas that recorded the most increase were how to demonstrate ways to meaningfully communicate intervention strategies with students and families, how to describe the distinct roles that school-based health center teams and school teams have in suicide prevention strategies, and how to identify and engage clinical and community partners. Again, we got some great qualitative feedback indicating their confidence level increasing and how they want to bring attention to this within not only their institution, but more on a district level audience as well. I will pass this off to Kristen now, who's going to talk a little bit about the ambassador echoes.
Thank you so much, Jessie. So as Corbin described earlier in the presentation, we had a series of clinical echo programs, and then we also had this really novel suicide prevention echo program, which really leveraged the power and local expertise of our AAP and AFSP chapters, and allowed them to connect with one another and advance youth suicide prevention in that regional and state level. And so our ECHO sessions really followed the traditional educational sessions that Jesse talked about before. You'll notice that instead of a case study, which may be typically used in a clinical ECHO program, we had what we called application of concepts. And so we asked our ambassador teams who were paired by state to do something within the next month before that next session. So it could be identifying other partners and learning about other partners. It could be connecting with youth in their area who may want to provide feedback on the topics that they focus on at that local level. And so our ambassador teams were tasked with this application of concept. And then we spent some time during each ECHO session to highlight some of those cases and provide our ambassador teams an opportunity to share what they've done and then lessons learned from that. And so our ECHO program engaged 95 ambassadors throughout our AAP and AFSP chapters. And then we also had 32 of those ambassadors join us for an additional media and advocacy ECHO, which we developed and created for our ambassadors based on their feedback. In the post-session evaluation, an overwhelming amount of ambassadors reported increased knowledge in the skills taught during the ECHO, which really centered around the community suicide prevention strategies that are described in the Blueprint for Youth Suicide Prevention. And then many of those ambassadors also reported an increase in confidence in their ability to apply the skills taught during the ECHO sessions. Next slide. And so this slide gives a brief overview of the community, and then, as I mentioned, the advocacy and policy ECHO cohorts of our Ambassador ECHO, including the types of faculty that we engaged, and then what the curriculum covered. In our traditional community ECHO cohorts, we engaged groups of multidisciplinary community suicide prevention experts, which is very similar to what Jesse was describing with our with our clinical ECHOs, but we also engaged individuals with lived experience. And engaging these individuals with lived experience was really essential to translate the curriculum's content to the efforts that the AAP and AFSP suicide prevention ambassadors were collaborating on. The curriculum centered around building participant capacity surrounding those community suicide prevention strategies described in the blueprint. And that includes building and maintaining community partnerships, because nobody does this work alone. And then for our advocacy and policy ECHO cohort, we engaged public affairs and public relations staff from each of our organizations at AAP and AFSP. These folks are really on the front lines of advancing our national advocacy and policy agendas. And then we also invited an AAP spokesperson who is a pediatrician for her to share her insights on local and national media engagement. So this cohort's curriculum centered around improving participant self-advocacy related to suicide prevention media and advocacy opportunities. And so then, in addition to the monthly ECHO sessions, AAP and AFSP ambassadors developed a chapter-level action plan. And this action plan consisted of measurable goals and activities to be achieved over a period of 12 months. Supported by a grant from the AAP chapter, the purpose of the action plan was for ambassador teams to better understand who the youth are in their communities, identify community partners to support them and partner with them in this work, and then collaborate to leverage current clinical and community networks to expand the reach of their efforts. And then just to kind of share with you some of the outcomes of this work, our Montana AAP and AFSP suicide prevention team knew that most households in their state owned a firearm. And so they developed this co-branded messaging that you'll see on the left that focuses on the role of secure firearm storage when preventing youth suicide. These messages were shared over both chapters' social media platforms to widen their reach. And then if you look on the right, that picture of that larger group, this is the South Carolina AAP chapter hosting a networking event for local pediatricians and mental and behavioral health professionals to increase knowledge of each other's services and to support relationship building across these professionals. And then at the bottom of the right-hand side of the screen, Maryland AAP, their suicide prevention team connected with a local organization to recruit Spanish-speaking youth to participate in 2 youth suicide prevention videos that are available on the Maryland AAP page. And then finally, our Mississippi AAP and AFSP chapter team partnered to host a virtual CME conference on pediatric youth suicide prevention, and that was aimed at primary care providers in their state. So all of this was possible because of the Suicide Prevention Ambassador Program. And then finally, for fun, it's hard to stay connected with one another in this virtual space. And we had folks who were participating and engaging across the country. And so our teams found ways to stay connected over the period of the program and even in this virtual community. So we had a bi-monthly newsletter that we sent to our ambassadors, and it allowed us to highlight resources that were coming out. It also allowed our ambassador teams to showcase and highlight their own successes in the work that they were doing. We hosted a monthly office hours session. You'll see some of us waving on the top right-hand screen, but that allowed us to bring in either local or national experts to take a deeper dive on a topic that was interesting for the suicide prevention ambassadors and chapter staff as well, who were really supporting the ambassador teams in advancing this work. And then at the bottom, we also had a collaboration site hosted through the AAP website. And that allowed us to compile all of the relevant resources and materials into one place so that our ambassadors and their chapter staff teams had access to that. And then
Awesome.
I'm going to turn it over to Corbin to help us wrap up with evaluation.
Yeah, thank you, Kristen and Jesse, for sharing those pieces. I'll just briefly talk about evaluation. Both Jesse and Kristen shared some of the evaluation and outcomes from both the clinical and ambassador programs, but we were really intentional about our evaluation approach, and it was a mixed methods evaluation design around our learning objectives and outcomes. Featuring kind of three key areas. One was key informant interviews and focus groups to collect some of that qualitative data related to peer support, sense of community, program perception. A lot of the feedback we got in those key informant interviews and focus groups is what went on to inform the updates, including putting evidence into practice, narrowing down the QI measures, all of these sorts of things. Participant surveys were also used to measure gains in knowledge, attitude change, intended behavior change. And again, those were after each session, and then a longer retrospective survey at the end of each cohort. We collected that data as well. And then the quality improvement metrics that were discussed by Jesse to measure changes in clinical practice and relevant patient health outcomes. Those measures were trimmed from 4 measures or to 4 measures from 8 measures to begin with, just to meet the needs of the participants in those QI echoes. But together, all of these three components really resulted in rich evaluation data and continuous improvement data that we continually fed into the program along the way to make improvements for our participants. I also just briefly want to talk about how we've been disseminating this work, including in this session here today, but in a variety of ways. We've really been trying to get the word out about the blueprint, about ECHO, and about how this work can look in pediatric and community settings. So in the top left, there are two publications out right now, one in the Journal of Public Health Management and Practice on how we developed a blueprint for youth suicide prevention, and the other in a special issue of Child and Adolescent Psychiatric Clinics of North America on collaborative approaches to universalizing suicide prevention, which we co-authored with Dr. Tammy Benton, who's been in this space for a long time as well. There's also a lot of case studies and blog posts that we've published. Dr. Rubinski, who was I believe a participant and I think a faculty member as well in our clinical echoes, talked about the Ambassador Project and the collaborations that they've done in their local chapters. We've also presented this work at many conferences over the last few years, including Meta Echo, which is a great annual conference in Albuquerque that brings together people all over the world who are utilizing the ECHO model, presenting at the International Summit on Suicide Research in Barcelona. A couple years ago, presenting at AMCHIP in Washington, D.C., the Association for Maternal and Child Health Programs, and a number of presentations around the country on this work. We've also been sharing through traditional media. Dr. Goodwin has been a participant in a number of our cohorts. Jesse mentioned she led some of the discussion about her engagement in media during our media and advocacy. Ambassador Echo, she was also interviewed on a radio show. We co-wrote a blog post with the Pew Charitable Trust, who helped fund this grant project on how pediatric healthcare teams can help prevent youth suicide. We wrote a blog for the National Health Council. We wrote a blog for American Foundation for Suicide Prevention's Real Stories blog. We were featured in the American Evaluation Association's AEA 365 blog last year as well. So really been trying to get it out, not just in conferences and publications, but also through traditional and online media as well. Um, and so we're also continuing to support implementation strategies through with for a variety of stakeholders and interest holders. There are a lot of resources available in the blueprint. The URL is there, aap.org/suicide prevention. There's a number of resources, including how to talk about suicide risk with patients and families. We worked really closely together to develop this one pager on the language to use, how to have this conversation with families and with children. We have a number of resources. One, again, co-developed with healthychildren.org about how we talk about suicide risk, what that looks like in families and schools and communities, and additional resources on how to talk about mental health and how pediatric clinicians and health providers can be a part of that conversation and are an important part of that conversation. Many people don't first think of pediatricians as being a go-to resource when it comes to mental health and suicide prevention, and so that's definitely one of the resources we're continuing to promote as well. I wanted to share this quote from one of our clinical echo participants, Dr. Eddie Salzberg. I got to interview him for one of our blog posts as well. And I always come back to this really powerful quote. He said, "We're always prepared for the asthma attack or seizure or a kid who isn't breathing. Now we have a mechanism for assessing suicide risk and feel more confident managing these critical encounters." So definitely encourage you to check out that blog post as well, but just a really powerful message from one of our participants. And so to wrap up, just a few lessons learned, and then I can open it up for Q&A. One is that operationalizing clinical best practices means supporting translators, or excuse me, supporting providers in translating principles in day-to-day practice. That was one of the key takeaways from this is how do we move from the what to the how when it comes to clinical practice and community best practices in suicide prevention. We also learned that that training needs to be combined with technical assistance to really build the capacity of learners to identify and support youth at risk for suicide and advance youth suicide prevention in community settings. We learned very quickly that it's important to be adaptable to change and meet the needs of the learners. It makes the content more relevant and it makes them more engaged in the content and more likely to implement these skills that they've learned afterwards. And of course, grounding these practices and implementation in health equity helps to ensure diverse patient needs are met. That was a piece that was embedded throughout the curriculum and in all of the sessions in both the clinical and ambassador echoes. And so with that, I'm happy to open it up for any questions. And again, thank you so much for your time.
I put a question, Corbin. Thanks so much for presenting this. I was part of the early thinking about this through my engagement with AFSP, and we had had those discussions all those years ago, and it's amazing to see that this has matured to where it is. It's really an incredible effort. I was curious about how the program was funded because when I think about it from a health systems change and from a research perspective, you've got to fund the people doing the work, like you guys, the core group of who sponsored and organized and ran the Echo. It's obviously a really daunting task to do that. And then also the sites themselves, have effort that they have to contribute if this is going to actually work and make a difference. So I'm just curious about how this effort was funded on both sides.
Yeah, I can speak to the sort of grant and project as a whole, and then maybe Jesse and Kristen can talk about practices themselves participating. But AFSP primarily funded the grant for the 3 years, going from 2022 to 2025. We wrapped that up last year, funding the initiative overall. We did get some funding as well from CVS Aetna and from the Pew Charitable Trusts, helped fund some of these pieces as well. So it was definitely collaborative effort with AFSP being the main funder of the project.
Yeah, thanks, Corbin. And I'll add that that grant from AFSP supported the chapter level work that AAP and AFSP suicide prevention ambassadors collaborated on. Due to the number of practices that participated in the clinical echo programs, we were unable to provide individual practice stipends or honorariums, but that's something that AAP is working towards in our next iteration of this implementation work. And so the Academy is actually building a suicide prevention training framework for primary care practices that we're hopefully piloting this summer. And in that pilot testing, we will be providing a stipend to those practices who are participating as a small token of our appreciation and recognition that this takes time and financial investment to do.
So the people who participated, the sites that participated, they basically were doing this out of the goodness of their heart. They wanted to participate because someone thought it was a good idea and worth the investment from the practice and the provider side um, to be able to improve care. So these are some really altruistic sites.
Yes, and I will say for many of them, it required gaining some sort of leadership buy-in and support from varying levels of their clinical practice. And so it really was, it usually started with one clinician who was really passionate and invested in this work. And it's through that leadership came on board and other clinicians and roles felt the responsibility to participate as well.
Great. Thank you.
Oh, I'll also add that also did provide a stipend to our faculty who led the echoes, so they were compensated.
This is Laura. We don't have any further questions in the Q&A at the moment, but I had a question around, I guess, similar to Dr. Boudreau's question around like motivations. Some of the things that you all were talking about might be best practices, but not necessarily like meeting the minimum standard for, say, Joint Commission. So when folks were moving more towards like really meeting best practice standards or like best practices, where did, I guess, the push or like the motivation for that come in, do you feel like?
Yeah, it's a good question. I think part of it is just that I go back to my interview with Dr. Eddie Salzberg, where he talked about having lost a patient to suicide and that kind of being one of the things that drove him to be really interested in this. There was a lot of sort of personal connection to it. Um, and I think sort of a recognition, and I think this is built into the curriculum in the early sessions around the scope of the issue, and that standards from the Joint Commission are great, but there's so much more that we know about what's effective when it comes to suicide prevention, especially when it comes to the basic clinical flow around screening, assessment, treatment, referral, follow-up. We know that there are tools out there that work. And so I think especially in those first few sessions, it was pretty easy to get people on board around going beyond what the Joint Commission's recommendations are. I think also, Kristen and Jesse, you could definitely speak more to AAP's recommendations around screening and how that came into play.
Yeah, thanks, Corbin. So after the launch of the Blueprint for Youth Suicide Prevention, the AAP updated their recommendations to reflect that universal screening should occur from pediatricians to all youth who are 12 years and older to screen for suicide risk using a validated suicide risk screening tool. And the Academy's and Bright Futures periodicity schedule was also updated to reflect that. And so I think for many pediatricians who are striving to meet that standard of care set by the Academy, that is certainly a motivation to achieve that and follow those policy recommendations from the Academy.
I will also say, just anecdotally, when we conversed with our participants, so many of them were seeing a dramatic increase of patients in their healthcare settings that came in with these risks and and they weren't sure how to deal or how to care for them. And so because of that, they turned to the academy and then joined us for these programs just because of how much they were seeing this.
Mhm. Did any of the sessions that include like debriefing? 'Cause that's one thing that I've heard healthcare providers say is very difficult to make time for are debriefing after a suicide death because it affects like all the clinician, it affects anyone. Was that part of some of the echo work as well?
Yeah, one of our sessions was on postvention
Mhm.
for all of them, and that included obviously the different audiences have different needs. School-based health center debriefing looks a lot different than a primary care setting. But yeah, we kind of intertwine that a lot with the physician burnout talk as well.
Yeah, we were really lucky to have Dr. Lisa Horowitz as part of our faculty panel for many of these echoes. And Lisa is a leader in youth suicide prevention, certainly, and also the processes and steps to take after a suicide occurs in your practice. And so we were very fortunate to have her as part of our faculty panel and support these steps.
Wonderful, thank you. Well, folks can still put some questions in the Q&A. Actually, I think one just came in. Um, we have a question. Was there any provider resistance to universal screening?
I would say it's usually not the providers who are resistant to universal screening. As Jesse said, many of the folks who participated saw the increased need and scope just from their own patient populations. I think part of the resistance comes from a larger system beyond just one clinician. And so, how do you get every clinician in your practice on board? How do you get leadership to buy into this, especially when there are certainly cases where you screen for suicide risk and then that turns into a positive. And so you need to be able to do something with that and have a process in place. And so I don't think that screening itself there was resistance, but I think it's this, as Jesse was mentioning, this unknown of what you do when a positive suicide risk screening occurs.
And I
Yeah, I
think
would say the people that joined the program were all pro.
Mhm.
They were there to learn how to more, but there was definite resistance from their practices sometimes. So with the staff at their, so we helped, well, not we, the subject matter experts helped individuals kind of figure out the best ways to go about the screening. So they do a PHQ-9, they just add the ASQ underneath right away, and or integrating that into your EHR, something to help them to show the staff that it wasn't as arduous. It wasn't going to be as big a time commitment as they thought it was. Of course, the ones that turn out to be yes, there is more to do. But working really one-on-one with the physicians who already had buy-in that joined us to get the rest of their practice to buy in was a focus of our program.
And I think another important point, as Kristen mentioned, is it's not our recommendation that you start with universal screening, right? You need to have all of these other systems in place first before you start screening everybody for suicide risk. Because if you do get that positive screen, you need to be able to then move to an assessment, treatment, referral, follow-up, and have all of those in place, and have that protocol in place. And so it was also part of the curriculum is like you don't need to start at universal screening. There are things you can do in the meantime while you're building that system to foster mental health wellness and suicide prevention in the clinical setting as you're working your way up to universal screening.
That makes sense. So you know what to do when someone tests screens positive. Um, Okay, I think we have time for maybe one more question. And just so folks know, we have a survey in the chat for feedback about the event and future events. But we have one more question from Dr. Benjamin Nephew. He asks, is there a recommendation for school-based universal screening or just with pediatricians? And for the school-based programs, was that at the high school or middle school levels?
I'll say so. The recommendations that AAP has is not based on um, like where the patient is being seen, but it's based on the screener and whether it's validated or not. So, for example, the ASQ, which was developed by Dr. Lisa Horowitz, is very specific to suicide versus asking about depression or thoughts of feeling unwell. And so, I think the taking a step back, the larger idea is to ensure that you're using a validated suicide risk screening tool, and that can certainly be used in school-based settings. I would have to check to see whether any of the school-based associations have recommendations. But you can certainly incorporate the ASQ or another validated suicide risk screener in a school setting. And then our school-based echo touched on middle school, but I would say really focused more on high school and then college-aged young people.
Great. Well, you all had many thank yous, and people were really grateful for sharing your expertise with us. Thanks on behalf of CAPES, and folks can look forward to the recordings and the slides in about a week or two.
Thank you all so much. Have a great
Thank
day.
you.